Welcome to the image analysis for the scapula. We will be discussing image analysis guidelines for common projections, the AP projection and the lateral scapula projection. We will be discussing common positioning errors and how to take corrective actions. Image analysis guidelines for the AP scapula projection state that the anterior and posterior margins of the glenoid cavity are nearly superimposed. The lateral scapular border is seen without thoracic cavity superimposition, while the thoracic cavity is superimposing the vertebral border. The superior angle of the scapula is seen without clavicular superimposition. The humeral shaft should demonstrate 90 degrees of abduction. The scapula is demonstrated without longitudinal foreshortening. The superior scapular angle is demonstrated slightly inferior to the clavicle. The mid-scapular body is at the center of the exposure field. The scapula should be all included within the exposure field. The scapular structures situated in the thorax demonstrate adequate contrast resolution. Here are those image analysis guidelines for your review. So let's talk about some positioning errors when positioning for an AP projection of the scapula. Proper humeral abduction and the shoulder retraction are critical for an optimal AP scapula projection. Any mispositioning can lead to foreshortening, superimposition, and reduced diagnostic quality. Inadequate abduction, meaning less than 60 degrees of the humerus, can cause the lateral scapular border to remain obscured by the thoracic cavity, while the clavicle superimposes the superior scapular angle. For a more clear lateral border, we need to ensure that at least 90 degrees of abduction is attained. Now let's take a look at what insufficient shoulder retraction does to our quality of imaging. Shoulder retraction also affects the clarity of the image. With the arm at the side, the scapula aligns 35 to 45 degrees to the IR, leading to transverse foreshortening. To correct this, the patient should be supine, the humerus should be abducted, the elbow should be flexed, and the hand supinated. This maneuver shifts the scapula laterally and posteriorly, minimizing that foreshortening and improving that glenoid cavity visualization. It's important if you are doing this projection standing, then you want to make sure that that mid-coronal plane is aligned with the IR. And so that may mean that you need to get them as parallel with the IR as possible to really ensure that we are reducing that foreshortening of that scapula. We have reached our first practice analysis. Go ahead and analyze the image and answer the following question. So let's look at this practice analysis together. In this AP scapular projection, improper positioning has led to some key misalignments. First, the infralateral scapular border is superimposed by the thoracic cavity. Second, the superior scapular angle is obscured by the clavicle. And third, the humerus is not sufficiently abducted. In order to correct this imaging, we need to abduct that humerus to that 90-degree angle with the torso. This adjustment moves the scapula laterally, clearing any superimpositions and ensuring optimal visualization of that scapular anatomy. Let's move on to the lateral projection of the scapula. Image analysis guidelines state for the lateral projection of the scapula that the superior scapular angle is just inferior to the clavicle. Longitudinal scapular body is demonstrated without foreshortening, and the superior scapular body is seen without overlap of the humeral head or glenoid cavity. The scapular body is in a lateral projection with superimposed lateral and vertebral scapular borders. The mid-scapular body is at the center of the exposure field, and the entire scapula is included within the exposure field. Here are those guidelines for your review. So I have a picture up here of an actual scapular Y projection, which is useful even in the lateral scapula projection. The only difference is the abduction of the arm. The arm should be up 90 degrees to free the scapular borders of superimposition of that humerus. However, you can determine mispositioning or malpositioning the same way as you do a scapular Y. You want to identify which border is the lateral border and which border is the medial border. In this case, when the medial border is closer to the thoracic cavity and the lateral border is away from the thoracic cavity, you are under-rotated. You can identify these borders easily by looking at which border is the thicker border. The lateral border is always thicker than the medial border. When the lateral border is closest to the thoracic cavity, as seen in this second image, and the medial border moves away from the thoracic cavity, you should easily be able to identify that this is over rotation, and we need to reduce that rotation in order to get both those borders superimposed. We are at the lateral scapular practice analysis. Go ahead and analyze this projection and answer the following question. So let's analyze this lateral scapular projection together. In this lateral projection, improper positioning has resulted in the lateral and vertebral scapular borders appearing separate instead of superimposed. The vertebral border, as you can see, is positioned much more closely to the ribs, indicating insufficient patient rotation. If you take a look, the superior scapular angle is positioned inferior to the coracoid. This suggests that the humerus is abducted a little excessively beyond the 90 degrees than it should be. In order to correct these errors, we want to increase that patient obliquity to properly align the scapular borders. In addition, we need to adduct the humerus to a 90-degree angle with the torso to reposition the scapula appropriately. This concludes the scapula projection presentations. If there's any questions or concerns, please feel free to reach out.